Welcome to your complete guide for the ATI Fundamentals exam. Every question breaks down why it's right, why others fail, and the rationale behind it. Our practice review covers the entire exam, including legal and ethical foundations, developmental tasks and stages, aseptic technique and precautions, safety and basic care, therapeutic communication skills, and one more thing. Don't forget that our website offers free study guides and practice questions designed to help you succeed on your ATI Fundamentals exam. You'll find the link right down in the description below, so be sure to check it out. Remember, the goal is to study smarter, not harder. Alright, let's get into it. Question 1. A client falls in the hallway and the nurse completes an incident report. Which action is correct regarding that report? Your options are A. File a copy inside the client's record. B. Record personal opinions about the cause. C. Note in the chart that a report was filed. D. Keep the report out of the medical record. Which one is it? Pause the video if you need more time. The correct answer is D. Keep the report out of the medical record. D is correct because an incident report supports quality improvement and stays separate from the medical record. The nurse documents the facts of the fall in the chart, but does not mention the report itself. A is wrong because placing the report in the client's record merges an internal quality document with the legal chart. The two are kept separate, so filing it inside the record is incorrect handling. B is wrong because recording opinions about why the fall happened introduces judgment into a factual document. An incident report should state only what occurred, without speculation about cause or assigning blame. C is wrong because writing in the chart that a report was filed creates a link the facility intends to avoid. The medical record should describe the event itself, not reference the separate incident report. When something unexpected happens to a client, two separate documentation tracks activate, and understanding why they stay separate is the key to this entire concept. For most of the 20th century, hospitals blamed individuals for errors, and staff simply stopped reporting because reporting invited punishment. Safety science eventually realized most errors come from flawed systems, not careless people. And keeping incident reports administratively separate from the clinical chart is what protects honest reporting. The same event feeds two parallel tracks. The medical record documents the client's condition and the care given, while the incident report routes to risk management so patterns can be analyzed across the institution, and neither ever references the other. Writing in the chart that an incident report was completed creates the exact link the process was designed to avoid, making the internal report discoverable. And the incident report itself must state only observable facts, never speculation, staffing opinions, or blame. Charting documents the client's condition and care. The incident report documents the event for institutional learning, and the two never mention each other. Question 2. A nurse is caring for an infant and teaching the parents to meet the infant's needs promptly. Which developmental task does this support? Your options are A. Developing trust. B. Gaining autonomy. C. Building initiative. D. Forming identity. Take a second. Which answer would you pick? The correct answer is A. Developing trust. A is correct because infants work on trust versus mistrust, learning that others reliably meet their needs. Responding promptly to feeding and comfort helps the infant develop a basic sense of trust. B is wrong because gaining autonomy is the task of the toddler years, not infancy. An infant is too young to assert independence, so this developmental task does not fit the infant stage. C is wrong because building initiative belongs to the preschool years, when children start activities on their own. An infant has not reached that stage, so initiative is not the task being supported. D is wrong because forming identity is the work of adolescence, far beyond infancy. Meeting an infant's needs supports trust, not the search for identity that comes many years later. Trust versus mistrust is the first stage in Erikson's model of psychosocial development, covering roughly the first year of life. The infant's central task is building a basic expectation that the world is dependable. An infant cannot feed, warm, or soothe itself, so every physical need is met through another person. When those needs are answered consistently, the infant learns that discomfort is temporary and that signaling brings relief. The mechanism is repetition, not perfection. An infant cries, a caregiver responds, and the need is met. Over hundreds of these cycles, the infant's stress response system calibrates around the expectation that signals work. Exam questions press on age matching. Autonomy belongs to the toddler asserting preferences, initiative to the preschooler pursuing plans, and identity to the adolescent capable of abstract self-reflection. An infant has none of those capacities yet, so trust is the only task available. Trust is not the same as attachment or bonding. It's a generalized expectation about the world, learned through consistent care in the first year. Anchor every stage to what the child can actually do, and the sequence becomes logic, not memorization. Question 3. A client receiving a tube feeding begins coughing and shows signs of possible aspiration. Which action should the nurse take first? Your options are A. Increase the rate of the feeding. B. Lay the client flat on the back. C. Give the client water to drink. D. Stop the feeding. Before I reveal it, which one do you think is right? The correct answer is D. Stop the feeding. D is correct because if aspiration is suspected during a tube feeding, the first action is to stop the feeding, so no more formula enters the airway. The nurse then turns the client and provides further care. A is wrong because increasing the rate of the feeding sends more formula in and worsens the aspiration. The nurse stops the feeding immediately rather than speeding it up when aspiration is suspected. B is wrong because laying the client flat lets formula flow towards the airway and increases aspiration. The client is turned to the side and the feeding is stopped first, not laid flat. C is wrong because giving water to drink during suspected aspiration adds more fluid to the airway and risks choking. The first step is to stop the feeding, not to offer anything by mouth. When formula enters the airway instead of the stomach during enteral feeding, the danger isn't just that fluid arrived, it's that the pump is still delivering more. Formula travels down a tube meant for the stomach, but if it refluxes upward or the tube tip shifts, the airway has no defense against fluid arriving from below, and the lungs cannot clear it. Gastric contents are acidic and formula is nutrient dense, so aspirated fluid injures lung tissue almost immediately and then feeds the bacteria that cause pneumonia. Because the damage is dose dependent, the volume that reaches the lungs is what determines severity. Every intervention besides stopping the pump treats formula that has already arrived, while stopping the infusion halts formula that is still entering the airway in real time. Prevention measures reduce risk beforehand, but once the event is happening, removing the source of harm always comes before treating its effects. Prioritization questions aren't asking which action matters most. They're asking which one comes first in time, and that answer is always the one that stops ongoing harm. Question 4. A nurse is caring for a client who had a stem cell transplant and is severely immunocompromised. Which intervention protects this client? Your options are a negative pressure room. B. Contact precautions with a gown. C. A protective environment with positive airflow. D. A shared room with another client. What's your answer? Commit to one before I continue. The correct answer is C. a protective environment with positive airflow. C is correct because a severely immunocompromised client needs a protective environment, which uses positive airflow and filtered air to keep organisms out. This shields a client whose weakened defenses cannot fight infection. A is wrong because a negative pressure room is designed to keep airborne organisms inside and away from others. This client needs protection from outside organisms, which calls for positive rather than negative airflow. B is wrong because contact precautions protect others from a client's organisms, not a vulnerable client from the environment. The goal here is to shield the immunocompromised client, which a gown alone does not accomplish. D is wrong because a shared room exposes an immunocompromised client to organisms carried by a roommate. Such a client needs a protective private setting, so sharing a room would increase the infection risk. A protective environment is a specialized room built to keep airborne organisms away from a client whose immune system cannot fight them off. It's defined by positive pressure airflow, HIPAA filtration, a high rate of air exchanges per hour, and sealed room construction that stops unfiltered air from leaking in. Air always moves from higher pressure to lower pressure. The room is held at higher pressure than the hallway, so filtered air continuously flows outward, and nothing from the corridor drifts in. Negative pressure rooms exist for the opposite problem. A client with tuberculosis, measles, or varicella is a source of infection, so that room is held at lower pressure to contain the hazard. A protective environment excludes the hazard instead. The direction is the entire distinction. When the client is vulnerable rather than contagious, the airflow required is positive. When the client is contagious by the airborne route, the required airflow is negative. Question 5. A nurse is delegating tasks during a busy shift. Which task is appropriate to assign to assistive personnel? Your options are A. Assisting a stable client with bathing. B. Teaching a client about new medications. C. Evaluating a client's response to treatment. D. Developing a client's care plan. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Assisting a stable client with bathing. A is correct because bathing a stable client is a routine, low-risk activity of daily living that fits the training of assistive personnel. Delegating it frees the nurse for tasks that require licensure. B is wrong because teaching about new medications requires nursing knowledge and judgment to confirm understanding. This responsibility stays with a licensed nurse and cannot be handed to unlicensed assistive personnel. C is wrong because evaluating a client's response to treatment is part of the nursing process and demands clinical analysis. Assistive personnel are not prepared to make that judgment, so this task is not delegable. D is wrong because developing a care plan relies on assessment and clinical reasoning reserved for the registered nurse. It falls well outside the routine support tasks assistive personnel are trained to perform. Delegation means handing off a task to someone else to perform, but the nurse never hands off accountability for how it turns out. That single distinction between responsibility and accountability is the entire concept. Assistive personnel become responsible for carrying out the task. The registered nurse stays answerable for whether delegating was appropriate, whether the person was competent, whether direction was given, and whether the outcome was checked. Accountability never transfers. The mechanism runs on the rights of delegation: the right task, the right circumstance, the right person, the right direction and communication, and the right supervision and evaluation. A task that clears every filter can be delegated. One that fails any single filter cannot. The exam trap is a stable client versus an unstable one performing the identical task. Ambulating a stable client is delegable, but the first walk after surgery requires judgment, so it stays with the nurse. The same split applies to vital signs. Stability decides, not the task name. Assignment distributes work that already sits within someone's scope, while delegation transfers a task outside it. Supervision is the direction and evaluation that follows both. In every case, the license behind the decision belongs to the nurse who made it. Question 6. A nurse cares for an adolescent who is exploring values and spending more time with peers. Which developmental task is the adolescent working on? Your options are A. Developing a sense of trust, B. Gaining autonomy, C. Building industry, D. Forming a personal identity. Which would you go with? Lock it in before the reveal. The correct answer is D. Forming a personal identity. D is correct because adolescents work on identity versus role confusion, exploring who they are. Examining values and turning toward peers reflects the search for a personal identity expected at this stage. A is wrong because developing basic trust is the infant's task of depending on caregivers. An adolescent exploring personal identity is many developmental stages beyond this earliest task belonging to early infancy. B is wrong because gaining autonomy is the toddler's struggle for independence. While adolescents seek independence too, their central task is forming identity, not the earlier toddler task of autonomy. C is wrong because building industry is the school-age child's focus on competence through accomplishment. The adolescent's main work is identity formation, which goes beyond simply developing a sense of industry. Erickson's adolescent stage, spanning roughly ages 12 to 18, centers on building a coherent sense of self out of values, beliefs, and social roles. Adolescents try on positions the way they try on clothing, and that experimentation is the developmental work itself. Two capacities arrive together at this age: formal operational thought, which lets teens reason abstractly and think about thinking, and mounting social pressure toward adult roles and choices. A person needs something coherent to commit from before committing to adult life, and identity work builds that something. The mechanism runs through the peer group, which acts as a laboratory outside the family where different versions of the self can be tested at low cost. Family bonds are fixed and long-standing, but peer relationships are provisional, letting a teen try a position, see how it lands, and keep or discard it. Exam writers test the pull of nearby stages. Intimacy versus isolation belongs to the young adult merging an identity with another person. Industry versus inferiority belongs to the school-age child mastering skills. And generativity belongs to middle adulthood guiding the next generation. Also distinguish identity from self-concept, the broader lifelong picture of how a person perceives themselves. Identity doesn't arrive all at once at a birthday. It forms through an ongoing process. And role confusion is simply the alternative outcome, not a disorder. Whenever a STEM places a teenager questioning values with peers, that pairing of age and self-examination points straight to identity versus role confusion. Question 7. A nurse applies sequential compression devices to an immobile client's legs. What is the purpose of these devices? Your options are A. To prevent skin infections, B. To strengthen the leg muscles, C. To promote venous blood return, D. To relieve the client's joint pain. Don't overthink it. Which one feels right? The correct answer is C. To promote venous blood return. C is correct because sequential compression devices inflate and deflate to push blood out of the leg veins and promote venous return. This helps prevent blood from pooling and lowers the risk of a clot forming. Is wrong because the devices do not prevent skin infections, which are addressed by hygiene and skin care. Their purpose is to move blood through the veins, not to protect against infection. B is wrong because the devices do not strengthen muscles, which requires active exercise. They work by compressing the legs to move venous blood, not by building muscle strength in the client. D is wrong because the devices are not intended to relieve joint pain. They support circulation by promoting venous return, which is a different goal from managing pain in the joints. Sequential compression devices don't treat clots or warm the skin. They exist to solve one specific physiologic problem, the loss of the calf muscle pump. Normally, every step you take contracts the calf muscle, squeezing deep veins and pushing blood upward toward the heart, while one-way valves keep it from falling back. Immobility, bed rest, anesthesia, or injury shuts the pump off entirely, so blood pools and stasis sets in. The sleeve inflates in sequence, ankle first, then calf, then thigh, mechanically pushing venous blood upward exactly as the calf muscle would. During deflation, veins refill with fresh blood, keeping flow moving instead of stagnant. Exam writers test what these devices are not. They do not treat an existing clot and may dislodge one if applied over a suspected DVT. They do not exist to reduce edema. They do not prevent pressure injuries, and they provide no anticoagulant effect. The underlying problem is always stasis from a missing calf pump, and the device's job is simply to keep that venous blood moving back toward the heart. Question 8. A nurse listens as an older adult reflects on life experiences with a sense of satisfaction. Which developmental task does this reflect? Your options are A. Integrity, B. Intimacy, C. Industry, D. Initiative. Got a guess? Lock it in. The correct answer is A. Integrity. A is correct because older adults work on integrity versus despair, reflecting on life with acceptance. Recalling experiences with satisfaction shows the older adult is achieving a healthy sense of integrity. B is wrong because intimacy is the young adult's task of forming close relationships. An older adult reflecting on a life lived is demonstrating integrity, not the earlier work of intimacy. C is wrong because industry is the school-age child's focus on mastering tasks. An older adult reviewing life with satisfaction is far past this stage, showing integrity rather than developing industry. D is wrong because initiative is the preschooler's task of starting activities. Reflecting on a whole life with acceptance reflects a sense of integrity, not the much earlier childhood task of developing initiative. Erikson's final stage of development belongs to later adulthood, when a person looks back and evaluates the whole life they've lived. Integrity is finding the whole arc of life, losses and wrong turns included, coherent and worth having lived. Despair is the alternative, regret over a life that feels wasted with no time left to fix it. The mechanism behind this stage is life review. An older adult returns to old episodes, examines past choices, and assembles them into a coherent story. This reminiscence is not confusion or decline. It's active psychological work, and when it succeeds, it produces acceptance. The tested nuance is how to respond. Redirecting an older adult away from the past or treating storytelling as confusion works against the task. Instead, listening, asking about events, and treating narration as meaningful supports the work, whether the emotional tone points toward integrity or despair. Don't confuse this with generativity versus stagnation, which looks outward at mentoring and contribution in middle adulthood. Integrity looks backward at a completed life, and that difference in direction separates the two stages cleanly. Question 9. A nurse is recording a client's intake and output. Which item should the nurse count as part of fluid intake? Your options are A. A solid slice of toast, B. A serving of mashed potato, C. The client's urine output, D. A serving of gelatin dessert. Which one is it? Pause the video if you need more time. The correct answer is D. A serving of gelatin dessert. D is correct because foods that are liquid at room temperature, such as gelatin, count as fluid intake. The nurse records gelatin under intake because it becomes liquid and contributes to the client's fluid balance. A is wrong because a solid slice of toast is a food, not a fluid, so it is not counted as intake on the fluid record. Only liquids and foods that melt to liquid are included in the count. B is wrong because mashed potato is a solid food that stays solid at room temperature and is not counted as fluid intake. It does not belong in the fluid portion of the record. C is wrong because urine is recorded under output, not intake. Counting it as intake would misclassify fluid leaving the body as fluid taken in, which distorts the client's fluid balance record. Intake and output measurement is the systematic tracking of every fluid entering and leaving the body, building a running picture of fluid balance that no single observation can supply. Fluid balance disorders develop silently and dangerously. A client in heart failure, one with kidney injury, one losing fluid to vomiting or drainage, and one receiving IV therapy all sit on a knife edge, and clinical signs like edema or dropping blood pressure appear only after imbalance is already established. The test is simple. Anything liquid at body or room temperature counts as intake, regardless of how it's served. Gelatin is water in a jail. Ice chips are frozen water counted at half volume, and broth, ice cream. And popsicles all belong in the intake column. Mashed potatoes, oatmeal, applesauce, and cooked cereal contain plenty of water, but they hold their form at body temperature, so they are not counted, while broth, gelatin, and coffee liquefy and go straight into the intake column. Every source counts, every team member applies the same rule, and records fail from missed items far more often than from math errors. Keep the operating rule in front. Measurable fluid in, measurable fluid out. Decided by physical state, not by nutritional value. Question 10. A client falls and breaks a wrist after a nurse failed to raise the bed rails. Which element needed to prove negligence does the broken wrist represent? Your options are A. Duty to provide care, B. Foreseeability of harm, C. Harm to the client, D. Breach of the standard. Take a second. Which answer would you pick? The correct answer is C. Harm to the client. C is correct because proving negligence requires that actual harm reach the client. The broken wrist is the real injury that resulted, satisfying the harm element that completes the case for negligence. A is wrong because duty refers to the care a nurse is obligated to provide by the standard. It describes the responsibility that existed, not the injury the client ultimately suffered from the fall. B is wrong because foreseeability means the nurse should have known the lapse could endanger the client. It addresses predictable risk beforehand, not the concrete injury the broken wrist actually represents. D is wrong because breach is the failure to meet the standard, such as leaving the rails down. It names the wrongful act itself rather than the resulting damage the client experienced afterward. Negligence is the failure to act as a reasonably prudent person would, and when a licensed professional is held to that profession's standard, the same conduct is called malpractice. Proving either one requires 4 elements and every single one must be present. The law needs the structure because medicine produces poor outcomes constantly for reasons involving no fault at all. If a bad result by itself created liability, no clinician could safely practice. So the 4 elements build a chain connecting a specific obligation to a specific failure to a specific injury. Duty is the professional relationship obligating care to a recognized standard. Breach is care falling below that standard. Causation means the breach actually produced the injury. Damages means real harm exists and a break anywhere in this chain ends the claim. Picture a high fall risk client whose care plan specifies raised rails. The nurse's assignment establishes duty. Leaving the rails down is the breach. The link between that omission and the fall is causation, and the fractured wrist is the damages. Don't confuse this with intentional torts like assault, battery, or false imprisonment, where the act itself is deliberate. Negligence and malpractice differ only by which standard applies, not by structure. So always ask whether the nurse intended the act that caused harm. Question 11. A nurse is planning care for a client on bed rest. How often should the nurse reposition the client to prevent skin breakdown? Your options are A, at least every 2 hours, B, once during the shift, C, only when the client asks, D, after every meal only. Before I reveal it, which one do you think is right? The correct answer is A, at least every 2 hours. A is correct because repositioning a client on bed rest at least every 2 hours relieves pressure on the skin and helps prevent breakdown. Regular turning keeps blood flowing to the areas that bear weight. B is wrong because turning the client only once during the shift leaves the skin under pressure far too long. Tissue damage can begin in that time, so much more frequent repositioning is needed. C is wrong because waiting until the client asks to be turned is unreliable, since a client may not feel the pressure. The nurse repositions on a regular schedule rather than depending on requests. D is wrong because repositioning only after meals does not match the schedule the skin needs. Pressure must be relieved at regular short intervals throughout the day, not just at meal times. Repositioning is a scheduled change in a client's body position that relieves pressure over bony prominences, and it happens at least every 2 hours around the clock. It's a preventive move against damage that starts invisibly long before any redness appears on the skin. Capillaries feeding the skin work at very low pressure, around 32 millimeters of mercury. Body weight on the sacrum, a heel, or a trochanter easily exceeds that, collapsing the vessel and cutting off oxygen, and the muscle nearest the bone dies first, before any skin change is visible. The interval exists because damage depends on both pressure and time trading against each other. Very high pressure injures tissue fast, while moderate pressure takes longer to cause the same harm. The 2-hour standard was set inside that tolerance window with margin, and turning lets blood flow return before the next loading cycle. Exam writers separate 3 related forces. Pressure is the perpendicular load that closes capillaries. Friction is surface rubbing that strips skin. And shear happens when the skeleton slides while skin stays put. Tearing vessels underneath, which is why a high head of bed angle is risky even with good repositioning. A pressure redistributing mattress lowers pressure but never eliminates it, so the schedule still holds, and clients with poor perfusion or fragile skin need turning even more often than that. Question 12. A nurse is performing a physical examination of a client's lungs. Which order of techniques should the nurse use? Your options are A, auscultate, then inspect and palpate. B, palpate, percuss, inspect, auscultate. C, percuss first, then inspect. D, inspect, palpate, percuss, auscultate. What's your answer? Commit to one before I continue. The correct answer is D. Inspect, palpate, percuss, auscultate. D is correct because for most body systems, the nurse inspects, then palpates, percusses, and auscultates. This order moves from least to most invasive and keeps the examination systematic and accurate for the lungs. A is wrong because beginning with auscultation skips inspection and palpation, which should come first for the lungs. Reordering this way breaks the standard sequence used for most body systems. B is wrong because starting with palpation places inspection out of its proper first position. The nurse inspects before touching, so this order does not follow the standard examination sequence. C is wrong because percussing first puts a later step ahead of inspection and palpation. The correct sequence begins with looking, so leading with percussion is out of order for the lungs. The physical exam always follows the same underlying logic. Gather information that costs the least before doing anything that changes what you're measuring. Inspection, palpation, percussion, and auscultation each disturb the body a little more than the last. If you do them out of order, an earlier step's disturbance contaminates what a later step finds. Picture a nurse assessing a client's lungs, first watching the chest rise, then feeling for phragmitus, then tapping for resonance, and only then listening with the stethoscope. Each step narrows what the next one is looking for. Every region follows inspect, palpate, percuss, auscultate, except the abdomen, where auscultation moves up to second place because touching or tapping the belly stimulates the bowel and changes the sounds you'd hear. Light palpation also always comes before deep palpation for the identical reason. Whether it's the 4 techniques, the abdominal exception, or light versus deep palpation, the rule never changes. Collect what costs nothing to collect before you do anything that alters the baseline. Question 13. A parent asks the nurse how to know when a toddler is ready for toilet training. Which sign indicates readiness? Your options are A. The toddler has only just turned 1. B. The parent feels it is time. C. The toddler recognizes the urge to go. D. The toddler sleeps through the night. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. The toddler recognizes the urge to go. C is correct because readiness for toilet training is shown by the toddler's awareness of the urge to urinate or defecate. Recognizing that sensation signals the child is developmentally prepared to begin. A is wrong because reaching a certain age alone does not indicate readiness, since children develop at different rates. Toilet training depends on signs of readiness, not on the birthday itself. B is wrong because the parent feeling it is time does not reflect the toddler's developmental readiness. Training succeeds when the child shows the needed signs, not when the parent decides on a schedule. D is wrong because sleeping through the night relates to rest patterns, not bladder and bowel awareness. Nighttime dryness develops last, so it is not the sign that training can begin. Toilet training isn't a skill parents install on a schedule. It's a coordination task that only becomes possible once a toddler's nervous system reaches specific maturational milestones. Infants empty by reflex with stretch receptors triggering the bladder automatically and no brain involvement at all. Voluntary control requires the nerve pathways between spinal cord and brain to myelinate, which typically finishes between 18 and 24 months. So before that, a toddler physically cannot hold on, no matter how motivated anyone is. The stretch receptors in the bladder wall send a signal up the spinal cord, but only once that pathway to the brain is mature does the signal reach conscious awareness. That's the moment a full bladder becomes a recognized sensation instead of just an automatic reflex. Several capacities have to arrive together, staying dry for a couple of hours, the motor skills to walk to the bathroom and manage clothing, enough language to communicate the need, and interest in imitating others. The capacity that matters most is recognizing the internal sensation before elimination happens, since noticing it afterward proves nothing about control. Adult-driven signs like a convenient season or a preschool deadline say nothing about a toddler's maturation, and age alone is unreliable since the window is wide. The rule to remember is that maturation sets the schedule, and the caregiver's job is simply to recognize readiness, not impose a timeline. Question 14. Assistive personnel warn a client that they will be tied down if they keep climbing out of bed. The nurse identifies this as which of the following? Your options are A. Assault, B. Battery, C. Negligence, D. False imprisonment. Which would you go with? Lock it in before the reveal. The correct answer is A. Assault. A is correct because assault is conduct that makes a client fearful and apprehensive, even without physical contact. A threat to tie the client down creates that fear by itself, which satisfies the definition of assault. B is wrong because battery requires actual unwanted physical contact, such as applying the restraints. Because the personnel only threatened and did not touch the client, the situation has not yet reached battery. C is wrong because negligence is a careless failure to meet the standard of care. This was a deliberate threat rather than an unintentional oversight, so it does not fit the meaning of negligence. D is wrong because false imprisonment means actually confining a client against their will. No restraint was applied and the client remained free to move, so a threat alone does not amount to confinement. These three intentional torts often arise from the same incident, but each protects something different. Learning to separate them by what actually happened in the scenario is the key skill being tested. Assault is the threat of harmful contact that creates reasonable fear, and it requires no physical touching at all. It has 4 conditions: an apparent present ability to act, the client actually being placed in apprehension, contact that would be harmful or offensive, and apprehension that is reasonable given the situation. Battery protects bodily integrity, the right not to be touched without consent, while assault protects mental security, the right to move through the world without fear of imminent harm. A credible threat that's never carried out can still cause real psychological harm, which is why the threat itself is legally actionable. Picture a client warned that if they keep getting out of bed, staff will tie them down. Nothing has been touched yet, so this is assault. If restraints are then actually applied without proper justification, that becomes battery. And if the client is prevented from leaving, that's false imprisonment. Don't be fooled by how serious the word assault sounds in everyday speech, since legally it points to the threat, not the force. Hold the sequence in order, and the scenario's physical facts will tell you exactly which tort applies. Question 15. A nurse is caring for a client who remains immobile in a chair for long periods. Which complication is the client at greatest risk for developing? Your options are A. A bone fracture, B. A pressure injury, C. A skin allergy, D. A hearing loss. Don't overthink it. Which one feels right? The correct answer is B. A pressure injury. B is correct because prolonged sitting places unrelieved pressure on the skin over bony areas, reducing blood flow and risking tissue damage. A pressure injury is the greatest risk for an immobile client in a chair. A is wrong because a bone fracture is not the direct result of sitting immobile in a chair. While immobility weakens bone over time, unrelieved pressure on the skin is the more immediate risk here. C is wrong because a skin allergy is caused by an allergen, not by pressure or immobility. The sustained pressure from prolonged sitting threatens the skin through reduced blood flow, not an allergic reaction. D is wrong because hearing loss is unrelated to sitting immobile in a chair. The pressure on the skin from prolonged sitting is what places this client at greatest risk for harm. Let's look at what actually happens beneath the skin when pressure builds over a bony prominence, and why the seated client is often at greater risk than the one lying in bed. Pressure injury damage begins deep, where bone compresses muscle against a surface, and it progresses outward toward the skin. This inside-out pattern explains why skin can look intact, even after serious tissue damage has already occurred underneath. Lying down spreads body weight across a large mattress surface, producing only moderate pressure. Sitting concentrates that same weight onto two small points, the ischial tuberosities, so a seated client actually experiences higher pressure than one lying down. Sitting also invites shear as the skeleton slides while skin stays fixed, tearing small vessels between layers. Moisture softens skin, and poor nutrition, low albumin, and reduced perfusion all shorten how long tissue can survive without blood flow, and a seated client often has several of these happening at once. Among immobility complications, skin breakdown develops fastest, often within hours, which is why sustained sitting or lying without repositioning signals the greatest risk. Remember, seated clients need repositioning more frequently than clients in bed, because their loading is more concentrated. Question 16. A nurse assesses a client's wound and notes redness, warmth, swelling, and tenderness. These findings indicate which response? Your options are A systemic body infection, B, an allergic reaction, C, normal healing tissue, D, a localized inflammatory response. Got a guess? Lock it in. The correct answer is D, a localized inflammatory response. D is correct because redness, warmth, swelling, and tenderness at one site are the classic signs of a localized inflammatory response. The body is reacting to injury or organisms in that specific area. A is wrong because a systemic infection produces body-wide findings such as fever, malaise, and a raised pulse. The signs here are confined to the wound, which points to a local rather than systemic response. B is wrong because an allergic reaction often brings itching, hives, or swelling from an allergen exposure. These wound findings reflect inflammation from injury or organisms, not an allergic hypersensitivity reaction. C is wrong because normal healing tissue appears pink and granulating without marked warmth and tenderness. The combination of redness, heat, and pain signals active inflammation rather than quiet, uncomplicated healing. Inflammation is the body's immediate, non-specific response to tissue injury, confined to the site where the damage occurred. It shows up as 4 classic signs recognized since antiquity, sometimes with a 5th. The 4 classic signs are redness, heat, swelling, and pain, with loss of function sometimes added as a 5th. These are not signs of failure. They mean the body's defenses have arrived and are working. Mast cells release histamine, causing arterioles to dilate, which brings the redness and warmth. Capillaries become more permeable, letting fluid leak out to cause swelling. And that fluid, along with chemical mediators, irritates nerve endings to cause pain, while neutrophils move in to clean up debris. Inflammation is the response, and infection is only one possible cause of it. A sterile surgical incision shows the same 4 signs with no organism present, but purulent drainage, foul odor, fever, and an elevated white count signal that infection has developed. The word localized matters because it tells you the response has stayed contained rather than becoming systemic. Pink, warm, mildly swollen incision edges with no drainage or fever are simply expected healing, not a complication. Question 17. A nurse is auscultating a client's heart and hears the sound that signals the beginning of ventricular contraction. Which heart sound is this? Your options are A, a pleural rub, B, an expected arterial bruit, C, the first heart sound, D, a friction rub. Which one is it? Pause the video if you need more time. The correct answer is C, the first heart sound. C is correct because the first heart sound marks the closure of the valves between the atria and ventricles and signals the start of ventricular contraction. This is the sound the nurse heard. A is wrong because a pleural rub is a lung sound from inflamed pleural surfaces, not a heart sound. It is unrelated to the start of ventricular contraction the nurse identified at the heart. B is wrong because a bruit is a swishing sound over an artery with obstructed flow, not a normal heart sound. It does not signal the beginning of the heart's ventricular contraction. D is wrong because a friction rub is a grating sound from inflamed surfaces rubbing together. It is not the heart sound that marks the onset of ventricular contraction the nurse heard. Let's build the pressure logic behind the lib dub. Every heart sound is really just a valve snapping shut in response to a pressure crossover, and once you see that, the whole cycle makes sense. Valves have no muscles of their own. They simply respond to whichever side has higher pressure. When ventricular pressure crosses above atrial pressure, the mitral and tricuspid valves snap shut, producing S1 and starting systole. When ventricular pressure later falls below arterial pressure, the aortic and pulmonic valves snap shut, producing S2 and starting diastole. The mitral and tricuspid valves are the atrioventricular valves, closing together to make S1. The aortic and pulmonic valves are the semilunar valves, closing together to make S2. Mixing up these two valve pairs reverses the entire framework. S1 is loudest at the apex, near the fifth intercostal space at the midclavicular line, and it lines up with the carotid pulse. S2 is loudest at the base, near the second intercostal spaces on either side of the sternum. Timing against the carotid pulse helps you tell them apart when the heart rate is fast. Murmurs, S3 and S4 are all extra sounds layered onto the same timeline, so identifying S1 and S2 correctly always comes first. Anchor everything to the two events that bounce systole, and the rest of cardiac auscultation falls into place. Question 18. A nurse cares for a school-aged child who is proud of completing schoolwork and projects. Which developmental task does this reflect? Your options are A. A sense of industry, B. A search for identity, C. Developing autonomy, D. Building basic trust. Take a second. Which answer would you pick? The correct answer is A. A sense of industry. A is correct because school-age children work on industry versus inferiority, gaining confidence by accomplishing tasks. Pride in finishing schoolwork reflects the developing sense of industry expected at this stage. B is wrong because A, search for identity, is the task of adolescence, not the school-age years. The child's pride in accomplishment points to industry rather than the later work of forming identity. C is wrong because developing autonomy is the toddler's task of asserting independence. A school-age child focused on mastering tasks is showing a sense of industry, not the earlier toddler drive for autonomy and independence. D is wrong because building basic trust is the infant's task of relying on caregivers. A school-age child taking pride in completed work is well past this stage, demonstrating industry instead. Erickson's fourth stage covers roughly ages 6 through 12. When a child's core task is building competence by producing work the culture values. The stage lands here because two things arrive together. School begins, bringing the first sustained evaluation by non-family adults, and the child gains concrete operational thought, the ability to follow systematic multi-step processes. Capacity and demand arrive at the same moment. The mechanism runs through completed projects. A child finishes an assignment, builds something, or earns a spot on a team, and that finished product becomes evidence, compared constantly against peers, which accumulates into a lasting self-assessment of competence. Don't confuse this with neighboring stages. Autonomy in toddlers concerns independence. Initiative in preschoolers concerns starting activities and pursuing plans. Industry concerns completing them to a standard, and identity in adolescence concerns who someone is rather than what they can do. Don't mistake this for academic achievement or general self-esteem. Industry is the school-age construction of competence through producing and completing work, whatever form that work takes. Question 19. A nurse is caring for a client with low self-esteem after an illness. Which nursing action best supports the client's self-concept? Your options are A. Point out the client's mistakes, B. Reinforce the client's strengths, C. Compare the client to others, D. Make decisions for the client. Before I reveal it, which one do you think is right? The correct answer is B. Reinforce the client's strengths. B is correct because reinforcing a client's strengths and successes helps rebuild self-esteem and a positive self-concept. The nurse highlights what the client does well to support their sense of worth. A is wrong because pointing out mistakes undermines an already low self-esteem. Focusing on failures works against the positive self-concept the nurse is trying to build with the client during recovery. C is wrong because comparing the client to others can deepen feelings of inadequacy. Self-concept improves by recognizing the client's own strengths, not by comparing them with other people or peers. D is wrong because making decisions for the client removes autonomy and signals doubt in their ability. Encouraging the client's own choices supports self-worth far more than taking over for them. Self-concept is the overall mental picture a person holds of themselves. It's built from 4 parts working together, and illness can attack all 4 at once. Body image is how someone perceives their physical appearance and function. Role performance is how well they feel they're meeting expectations as a parent, worker, or partner. Personal identity is the sense of being a distinct individual, and self-esteem is the evaluative layer judging whether that self is worth much. Telling a client everything will be fine offers no proof and can dismiss a valid concern. What actually rebuilds self-esteem is concrete evidence, like helping a client notice a skill or capacity that survived the illness. Students often confuse self-concept, self-esteem, and body image, but these terms sit inside one another rather than beside one another. Self-concept is the whole picture. Self-esteem is the evaluation of that picture, and body image is just the physical piece within it. Whenever a scenario mentions feeling useless, loss of independence, or altered body image, look for the answer that supplies real evidence of remaining capability, not the one that reassures, minimizes, or compares. Question 20. A nurse is teaching a client who uses a corticosteroid inhaler. Which instruction helped prevent a fungal infection in the mouth? Your options are A. Avoid drinking water all day. B. Use the inhaler only once a week. C. Hold the breath for a full minute. D. Rinse the mouth after each use. What's your answer? Commit to one before I continue. The correct answer is D. Rinse the mouth after each use. D is correct because rinsing the mouth after each use of a corticosteroid inhaler removes residual medication that can lead to a fungal infection. The nurse teaches this simple step to protect the client's mouth and throat. A is wrong because avoiding water all day does not prevent a fungal infection and could cause dehydration. Rinsing the mouth after the inhaler, not limiting fluids, is the protective measure here. B is wrong because using the inhaler only once a week ignores the prescribed schedule and would undertreat the condition. The client follows the prescription and rinses the mouth to prevent infection. C is wrong because holding the breath helps the medication reach the lungs but does not prevent a mouth infection. Rinsing afterward is the step that removes residue and protects against fungal growth. Oral thrush is the most common local side effect of inhaled corticosteroids, and understanding why it happens explains exactly how to prevent it. Inhaled corticosteroids suppress inflammation in the airway, but a large fraction of each dose never gets that far, instead landing in the mouth and throat, there. It suppresses local immune defenses, letting Candida albicans, an organism normally kept in check, overgrow into thrush. Prevention follows directly from the mechanism. Rinsing and spitting removes deposited drug before it acts. Gargling extends that protection to the throat, and a spacer lets large droplets fall out before hitting the mouth, cutting oral deposition while boosting lung delivery. Students often blend these instructions together, but each solves a distinct problem. Rinsing prevents fungal overgrowth. Waiting between puffs allows the airway to respond before the next dose. And using the bronchodilator before the corticosteroid ensures the airways open so the anti-inflammatory drug reaches deeper. Remember, inhaled corticosteroids are controllers, not rescue medications. And rinsing addresses thrush specifically, not sudden breathlessness. Anchor each teaching point to the problem it solves, and it becomes retrievable under pressure. Question 21. A client begins to talk about fears related to dying, and the nurse immediately starts discussing the meal schedule. Which barrier did the nurse use? Your options are A. Using purposeful silence, B. Offering self, C. Changing the subject, D. Active listening. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Changing the subject. C is correct because shifting to the meal schedule when the client raises fears about dying is changing the subject. A communication barrier. It steers away from a meaningful concern the client wanted to share. A is wrong because using purposeful silence would mean pausing to let the client continue sharing. The nurse instead redirected the conversation, which is the opposite of allowing supportive silence in the moment. B is wrong because offering self would mean expressing willingness to spend time with the client. The nurse moved away from the topic instead, so this is not offering self. D is wrong because active listening would mean attending to and acknowledging the client's fears. By abruptly switching topics, the nurse did the opposite of listening to the client's real concern here. Changing the subject is a non-therapeutic technique where the listener redirects the conversation away from what the speaker introduced. It works as a barrier because it takes control of the exchange away from the person raising the concern and hands it to the listener. Everyday conversation is built to keep people comfortable, so steering away from distressing topics feels polite. But clinical communication has the opposite goal. It exists to help a client express what's happening internally, and the hardest topics to raise usually carry the most weight. When a client raises fear of dying and the response shifts to lunch, the client receives a clear message. The subject is not welcome here. Most clients never raise it again, so the opportunity doesn't just get postponed, it usually closes. Exam writers test the difference between changing the subject and its relatives. False reassurance dismisses a concern. Giving advice substitutes the nurse's judgment. Asking why demands justification. Offering a cliché replaces engagement. And defending protects an institution. Each ends exploration through a different mechanism. The concerns clients hesitate to raise are exactly the ones needing expression most. So the right move is exploration, not redirection. If the nurse's response addresses a different subject than the client raised, a barrier has been used, no matter how kindly it was phrased. Question 22. A nurse wants to reduce the risk of healthcare-associated infections on the unit. Which action is the most effective way to do this? Your options are A. Perform frequent and effective hand hygiene. B. Wear a mask for every client. C. Place all clients in private rooms. D. Limit the number of visitors. Which would you go with? Lock it in before the reveal. The correct answer is A. Perform frequent and effective hand hygiene. A is correct because frequent, effective hand hygiene is the single best way to prevent healthcare-associated infections. Cleaning the hands before and after every client contact breaks the most common route of transmission on the unit. B is wrong because wearing a mask for every client guards against respiratory spread, but does not address the contact transmission that causes most of these infections. Hand hygiene remains the stronger prevention measure. C is wrong because placing all clients in private rooms is unnecessary and does not target how these infections usually spread. Most are transmitted by hands, so room assignment is not the most effective step. D is wrong because limiting visitors has little effect on the organism staff carry between clients. The greatest reduction comes from clean hands, not from controlling how many people enter the unit. Hand hygiene, removing microorganisms by washing or using alcohol rub, is the single most effective way to prevent healthcare-associated infections. That ranking exists because hands are the pathway pathogens use most often to move between clients and surfaces. In 1840s Vienna, Ignaz Semmelweis noticed physicians who performed autopsies before deliveries caused far more maternal deaths than midwives who did not. Requiring hand washing between the two dropped mortality immediately, even though no one could yet explain why. Every infection needs a route from a reservoir to a new host, and in a facility that route runs through contact. Hands connect a client's skin, a bed rail, or a wound to the next surface or the next person, making hands the single link that breaks the whole chain. Alcohol-based rub is preferred for routine hand hygiene because it's faster, more accessible, and gentler on skin. But soap and water is required when hands are visibly soiled, and specifically after caring for a client with Clostridioides difficile, because alcohol does not kill spores. PPE cleaning schedules and isolation precautions only apply to specific moments or known cases. Hand hygiene applies constantly at every single contact, which is exactly why it outperforms every other infection control measure. Question 23. A nurse is curious about the diagnosis of a client on another unit who is not under the nurse's care. Which action is appropriate? Your options are open the record to satisfy the curiosity. B. Refrain from accessing the client's record. C. Ask a co-worker to look it up. D. Share the question with the team. Don't overthink it. Which one feels right? The correct answer is B. Refrain from accessing the client's record. B is correct because only team members directly responsible for a client's care may access that record. Because the nurse is not caring for this client, refraining from opening the record follows the privacy rule. A is wrong because opening a record out of curiosity is an unauthorized access and a privacy violation. Having login ability does not grant permission to view clients the nurse is not caring for. C is wrong because asking a co-worker to look up the information still results in unauthorized access to protected data. Routing the request through someone else does not make the snooping acceptable. D is wrong because raising the question with the team spreads interest in private information the nurse has no right to view. The appropriate choice is to leave the unrelated client's record alone. Health information belongs to the client and HIPAA governs who may access it. The rule is simple. Access is tied to a care relationship, not to employment, curiosity, or good intentions. A diagnosis can affect someone's employment, custody, insurance, or immigration status. Before federal regulation, protection depended on institutional policy and personal ethics, and enforcement was inconsistent. As records moved from locked paper files to electronic systems reachable from any terminal, regulation had to replace physical barriers with legal, enforceable ones. The mechanism is access tied to a care relationship. An assigned nurse has a legitimate reason to open the chart. An unassigned nurse does not, no matter their skill or curiosity. Every system logs who opened a record and when, and audit software flags access that doesn't match assignments. Students often blur three related ideas. Privacy is the client's right to control their information. Confidentiality is the obligation of those who hold it to protect it. Security is the technical and physical safeguards like passwords, encryption, and automatic log-off that make protection possible. Unauthorized chart access violates all three at once. Wanting to learn from an interesting case, worrying about a neighbor, or asking a colleague to look instead of looking yourself are all still violations. When there's no care relationship, the correct action is to refrain entirely and to seek knowledge through proper channels instead. Question 24. A nurse is monitoring a client receiving an opioid for pain. Which finding should the nurse recognize as an early warning of respiratory depression? Your options are A. Increased urine output. B. A rise in respiratory rate. C. Improved alertness. D. Increasing sedation and drowsiness. Got a guess? Lock it in. The correct answer is D. Increasing sedation and drowsiness. D is correct because increasing sedation precedes respiratory depression from opioids when a client becomes difficult to keep awake. The nurse recognizes this as an early warning and monitors breathing closely before it slows dangerously. I is wrong because increased urine output is not a warning sign of opioid-related respiratory depression. Opioids more often cause urinary retention, so this finding does not signal the developing danger. B is wrong because a rising respiratory rate is the opposite of what occurs with opioid respiratory depression, where breathing slows. An increasing rate would not be the early warning the nurse watches for. C is wrong because improved alertness suggests the client is doing well, not heading toward respiratory depression. The warning sign is growing sedation, which is the reverse of becoming more alert. Opioids act on the brainstem, producing analgesia, sedation, and respiratory depression together, but these effects do not arrive all at once. Understanding the order they appear in is the key to catching danger early. Opioids bind receptors in the medulla, the brainstem region, that controls the automatic urge to breathe. The same receptor activity blunts the body's response to rising carbon dioxide, which is normally the trigger for the next breath. The effects follow a predictable order: analgesia first, then sedation, then respiratory depression. Sedation is the early warning sign, and a falling respiratory rate is the late one. Respiratory rate changes only after significant depression has occurred, and oxygen saturation lags even further behind, especially with supplemental oxygen masking the danger. A structured sedation scale is the measure that moves first, and risk is highest in opioid-naive clients, older adults, those with sleep apnea or obesity, and anyone also taking other central nervous system depressants. A drowsy client who is hard to rouse is the moment to act, not the moment to wait. Recognizing sedation early is what keeps a manageable situation from becoming an emergency. Question 25. A nurse is setting priorities for a client who has several needs. Which need should the nurse address first? Your options are: A. The client's worry about finances. B. The client's request for a visitor. C. The client's need for adequate oxygen. D. The client's concern about self-image. Which one is it? Pause the video if you need more time. The correct answer is C. The client's need for adequate oxygen. C is correct because Maslow's hierarchy places physiological needs at the base, so they take priority. Ensuring the client has adequate oxygen comes before psychological or social concerns, which the nurse addresses afterward. I is wrong because worry about finances is a real concern but sits higher on the hierarchy than physiological needs. The nurse meets basic physical requirements before turning to the client's financial stress. B is wrong because a request for a visitor reflects a love and belonging need, which ranks above basic survival needs. The nurse satisfies physiological priorities first and arranges the social visit a bit later. D is wrong because concern about self-image relates to self-esteem, near the top of the hierarchy. Such needs are met after the client's physiological requirements are met, and the client is stable and secure. When a client presents with several real needs at once, nurses need a reliable way to decide what comes first. Two frameworks solve this problem, and they agree with each other. Maslow's hierarchy stacks physiologic needs beneath safety, love and belonging, esteem, and self-actualization. The idea is simple. Needs that sustain biological life must be met before needs that make life meaningful can be pursued. Inside the physiologic tier itself, airway, breathing, and circulation form their own internal order. Airway outranks breathing, which outranks circulation because oxygen delivery to the brain has the shortest margin, before irreversible damage occurs. The hierarchy has refinements test writers love. Actual problems outrank potential ones, unstable clients outrank stable ones, and immediate safety threats, like an actively suicidal client or a fire, outrank routine physiologic care. Remember, the hierarchy answers what comes first in a single moment, not what matters most overall. Every need gets addressed, and the order is what keeps the client safe. Question 26. A nurse is caring for a client who has restraints in place. Which action should the nurse include in the plan of care? Your options are: A. Check circulation and skin at regular intervals. B. Remove the restraints only upon client discharge. C. Tighten the restraints for security. D. Document the behavior once per shift. Take a second. Which answer would you pick? The correct answer is A. Check circulation and skin at regular intervals. A is correct because a restrained client needs regular checks of circulation, skin integrity, and basic needs. Along with range of motion, frequent monitoring prevents complications such as skin breakdown and impaired circulation. B is wrong because waiting until discharge to remove restraints ignores the need to release them frequently. Restraints are removed at intervals to allow movement, circulation, and skin care for the client. C is wrong because tightening the restraints for security risks, cutting off circulation, and harming the skin. Restraints stay loose enough for 2 fingers to fit, not tightened down on the limb. D is wrong because documenting only once per shift fails to capture the frequent monitoring restraints require. The nurse records assessments and care at regular short intervals while the restraints remain in place. A restraint is any device, material, or medication that restricts a client's movement or access to their own body and cannot be removed by the client. It is always a last resort, used only after least restrictive alternatives have failed. Restrained clients have died from strangulation in vests, asphyxia in prone positions, and vascular compromise in tight limb devices. Beyond direct injury, restraint causes circulatory impairment, skin breakdown, muscle atrophy, aspiration, delirium, and loss of dignity, and it does not even reliably prevent falls. A restraint requires a specific prescription for type, location, duration, and justifying behavior, never a standing order. It must be tied to the bed frame with a quick release knot, never to a side rail that moves when the bed is adjusted. The greatest danger develops silently underneath the device, so frequent checks of circulation, skin integrity, and neurovascular status are the core of the care plan. Nurses must also reposition the limb, provide range of motion, and offer toileting and fluids at each round. The purpose the device serves, and whether the client can remove it, always determines whether it counts as a restraint. Continuous monitoring is not documentation on the side. It is the very intervention that keeps the restraint from causing the harm it was meant to prevent. Question 27. A nurse explains a procedure to a school-aged child using a simple model they can see and handle. Which reasoning style does this match? Your options are: A. Abstract thinking, B. Concrete thinking, C. Reflexive thinking, D. Magical thinking. Before I reveal it, which one do you think is right? The correct answer is B. Concrete thinking. B is correct because school-age children think concretely, understanding best through real, tangible examples. Using a model the child can see and handle matches the child's concrete reasoning style well. A is wrong because abstract thinking, which handles hypothetical ideas, develops later in adolescence. A school-age child relies on concrete examples, so an abstract explanation would not match their reasoning. C is wrong because reflexive thinking is not a recognized stage of cognitive development. The child reasons concretely, So a tangible model fits their thinking rather than this non-existent thinking style. D is wrong because magical thinking belongs to the preschool years, where wishes seem to cause events. A school-age child reasons more logically, relying on concrete rather than magical thinking to make sense of the world. Piaget's third stage of cognitive development, roughly ages 7 to 11, is when children reason logically about real objects and events but still cannot reliably reason about abstractions or hypotheticals. Piaget saw development as qualitatively different stages, not steady learning. The sensorimotor infant knows the world through action. The pre-operational preschooler reasons intuitively with symbols. The concrete operational child gains true mental operations on real things. And the formal operational adolescent extends logic to the abstract. The stages mechanism shows up in specific capacities. Conservation. So pouring liquid into a taller glass doesn't change the amount. Reversibility. Mentally undoing an action. Classification and seriation. Sorting and ordering objects. And reliable cause and effect reasoning. All of these operate on things a child can picture, handle, or has directly experienced. A nurse preparing an 8-year-old brings the actual tubing, lets the child hold it, shows on a doll where it will go, and describes sensations in specific literal terms, walking through the sequence step by step. This concrete, hands-on approach is what makes the explanation understandable at this age. Pre-operational children think intuitively and may see illness as punishment, while formal operational adolescents can weigh abstract, long-term risks. Concrete operational thought sits between the two, real logic applied to real things. So effective teaching always puts something tangible in the child's hands. Question 27. A nurse applies restraints to keep a competent client who wants to leave from exiting the facility. The nurse should identify this action as which of the following? Your options are A. Assault, B. Beneficence, C. Negligence, D. False imprisonment. What's your answer? Commit to one before I continue. The correct answer is D. False imprisonment. D is correct because false imprisonment is confining or restraining a competent client against their will. Using restraints to stop the client from leaving unlawfully limits freedom, which is exactly what this tort describes. A is wrong because assault is creating fear of harm without contact. The nurse did more than threaten, physically restraining the client, so the act goes past assault into unlawful confinement of the client. B is wrong because beneficence is an ethical principle of doing good, not a tort. Restraining a competent client against their will causes harm and restricts freedom, which does not promote the client's good. C is wrong because negligence is an unintentional failure in care. Restraining the client to prevent departure was a deliberate act, so it does not match the accidental nature that negligence requires. False imprisonment is the intentional confinement of a person within fixed boundaries, without legal authority and without consent. In healthcare, it takes the form of physical restraint, a locked exit, or a threat that convinces a client they cannot leave. Healthcare creates unusual risk for this tort, since staff have real power over movement and clients are often weakened or dependent. Lawful confinement exists only in narrow situations, immediate danger, a valid involuntary commitment, a court order, or a documented restraint prescription. Without one of these, restricting a competent adult who wants to leave is confinement without authority. The claim requires that confinement be intentional rather than accidental, that the person be aware of it or harmed by it, and that no lawful justification exists. Clinical concern about a client's safety is not the same thing as legal authority to confine them. Students often confuse this tort with its neighbors. Assault is the threat of contact. Battery is the contact itself. And false imprisonment is the restriction of movement. A single episode can produce all three. Negligence is different entirely since it involves a failure to meet a standard rather than a deliberate act. When a competent client wants to leave, the correct response is to inform, document, and let them go, never to physically prevent them. Ask what was intentionally done and what interest it invaded, and the classification follows. Question 29. A nurse is assigning a room to a client who is confused and at high risk for falls. Which placement is most appropriate? Your options are A. A room at the end of the hall. B. A room with the door closed. C. A room near the nurse's station. D. A private room away from staff. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. A room near the nurse's station. C is correct because placing a confused, high-risk client near the nurse's station allows staff to observe and respond quickly. Close monitoring is a key strategy for preventing falls in a client who cannot reliably call for help. A is wrong because a room at the end of the hall keeps the client far from staff and delays response to problems. Distance reduces observation, which raises the fall risk for a confused client. B is wrong because closing the door limits the staff's ability to see and hear the client. A high-risk, confused client benefits from visibility, so reducing observation works against safe fall prevention. D is wrong because placing the client far from staff removes the close monitoring the situation requires. A confused client at high risk needs more observation, not the isolation of a distant room. Why does moving a confused patient closer to the nurse's station prevent falls better than teaching them to ask for help? The answer lies in matching the intervention to what the patient's brain can actually do. Cool lights and safety teaching only work if the client can retain and act on them. Confusion breaks that assumption entirely. So the only protection left is observation, catching the client before the fall rather than relying on them to ask for help. Nearness to the station increases incidental observation and shortens response time. Around that call, the bed is kept low and locked. The client wears non-skid footwear, the path is cleared. Hourly rounding proactively offers toileting, and medications are reviewed as a modifiable cause. Placing the room within routine line of sight means staff notice the client incidentally, without needing a formal check, and can respond within seconds when an alarm sounds. Exam writers test the pull toward restraint. A distant private room removes the client from view, and raising all four side rails just turns the bed into a restraint, risking falls from greater height. The organizing principle is always to increase observation and reduce reasons for unassisted movement, never to restrict. Question 30. A nurse is instilling prescribed eye drops for a client. Where should the nurse place the drops? Your options are A. Into the lower conjunctival sac. B. Directly onto the cornea. C. At the inner corner of the eye. D. On the upper eyelid surface. Which would you go with? Lock it in before the reveal. The correct answer is A. Into the lower conjunctival sac. A is correct because eye drops are placed into the lower conjunctival sac, formed by gently pulling down the lower lid. This avoids the sensitive cornea and lets the medication spread safely across the eye. B is wrong because placing drops directly onto the cornea is uncomfortable and can trigger blinking that expels the medication. The drops go into the lower conjunctival sac instead of onto the cornea. C is wrong because dropping medication at the inner corner lets it drain into the tear duct rather than coat the eye. The lower conjunctival sac is the correct location for instilling eye drops. D is wrong because placing drops on the upper eyelid surface does not deliver the medication into the eye. The drops belong in the lower conjunctival sac, not on the outside of the lid. Correct eye drop technique means placing medication into the lower conjunctival sac, not directly onto the cornea, iris, or outer corner of the eye. The cornea is one of the most densely innervated tissues in the body, so a drop landing there causes stinging, reflex blinking, and tearing that flushes out the medication before it can absorb. The conjunctival sac, being far less sensitive and able to hold the drop near the target surface, avoids this entirely. To administer correctly, tilt the head back. Look upward to move the cornea out of the way. Gently pull the lower lid down to expose the sac, and release one drop without letting the dropper touch the lid, lashes, or eye. After installation, applying gentle pressure over the inner canthus for 30 to 60 seconds blocks the nasolacrimal duct, keeping the drug on the eye and limiting systemic absorption, which matters most with beta blocker glaucoma drops that can cause bradycardia or bronchospasm. Since the sac holds only about one drop, multiple drops of the same medication need several minutes between them. Different medications need longer spacing, and ointments go on after drops. Keep ophthalmic and otic techniques separate in your mind. Eye drops target the lower conjunctival sac while avoiding the cornea, and ear drops require straightening the canal instead. So don't let the two blend together. Question 31. A nurse reviews several clients to identify who is most at risk for developing an infection. Which client is the most susceptible host? Your options are A client who exercises regularly, B, a client who is immunocompromised, C, a client eating a balanced diet, D, a client with intact, healthy skin. Don't overthink it. Which one feels right? The correct answer is B, a client who is immunocompromised. B is correct because a susceptible host has weakened defenses against organisms. A client who is immunocompromised lacks the normal immune protection, making this client the most vulnerable to developing an infection. A is wrong because a client who exercises regularly tends to have stronger general health and defenses. Good fitness lowers rather than raises susceptibility, so this client is not the most at risk. C is wrong because a client eating a balanced diet supports immune function through good nutrition. Adequate nutrition strengthens the body's defenses, which makes this client less susceptible to developing an infection. D is wrong because a client with intact, healthy skin retains the body's first line of defense. Unbroken skin blocks organisms from entering, so this client is better protected, not more susceptible. The susceptible host is one link in the chain of infection, and it names the person whose defenses cannot repel an invading organism. This chain describes the full sequence an infection must complete. The chain runs from an infectious agent to the reservoir where it lives, to a portal of exit, a mode of transmission, a portal of entry, and finally the susceptible host. Every link must hold for infection to occur, which means breaking any single one stops it, regardless of the rest. Normal defenses work in layers. Intact skin and mucous membranes form a physical barrier. Stomach acid, tears, cilia, and normal flora add chemical protection. Neutrophils and macrophages respond to what gets through, and antibodies supply targeted immunity. A client is susceptible to the degree these layers are missing or weakened. Immunocompromise from chemotherapy, corticosteroids, or advanced HIV is categorically different from a single breach. Because it disables the cellular defenses, every other layer depends on for backup. That is why a neutropenic client outranks a client with just a healing incision or a catheter. When a question compares several clients, trace each one's defenses. The client whose immune system itself is failing is the most susceptible host because organisms others clear silently become invasive infections in them. Question 32. A client says, "I'm worried about how my family will manage." The nurse responds, "You sound concerned about your family." Which technique did the nurse use? Your options are A. Giving advice. B. False reassurance. C. Changing the subject. D. Reflecting. Got a guess? Lock it in. The correct answer is D. Reflecting. D is correct because reflecting directs the client's feelings back to them so they can explore those feelings further. By naming the concern the client expressed, the nurse used the reflecting technique. A is wrong because giving advice would mean telling the client what to do about the family. The nurse instead mirrored the client's feeling, which is reflecting rather than giving advice. B is wrong because false reassurance would dismiss the worry with an empty promise that everything will be fine. The nurse acknowledged the feeling instead, which is reflection, not false reassurance. C is wrong because changing the subject would steer away from the family concern the client raised. The nurse stayed with the feeling and reflected it back rather than shifting topics. Reflecting is a therapeutic technique where the nurse restates the client's underlying feeling, not just their words, and offers it back for confirmation or correction. This signals that the concern registered and keeps attention on the client. Instead of solving the problem or repeating the sentence back, reflecting names the emotion hiding underneath what was said, like holding up a mirror to what the client is really feeling. Exam writers test the difference between 4 look-alike techniques. Restating repeats content in similar words. Reflecting names the feeling behind the content. Clarifying asks for more information when meaning is unclear. And summarizing pulls together the main points at the end. The mechanism produces 2 effects: verification, where naming the emotion lets the client confirm or correct it, and permission, where hearing the feeling said aloud makes it feel acceptable to explore further. This is why reflection acts as an invitation without ever asking a question. So whenever a client's statement carries emotional weight, and the nurse's response names that feeling using words like sounds like or seems, that is reflection at work. Question 33. A nurse needs to discuss sensitive health topics with an adolescent. Which approach best encourages open communication? Your options are: A. Discuss everything in front of parents. B. Use a stern, lecturing tone. C. Speak privately and without judgment. D. Avoid the sensitive topics entirely. Which one is it? Pause the video if you need more time. The correct answer is C. Speak privately and without judgment. C is correct because adolescents share more openly when they feel respected and unjudged. Speaking privately and without judgment builds trust and encourages honest discussion of the sensitive health concerns an adolescent may have. A is wrong because discussing everything in front of parents can make an adolescent reluctant to be honest. Privacy encourages openness, so including parents in every sensitive topic discourages sharing. B is wrong because a stern lecturing tone shuts down communication and invites defensiveness. Adolescents respond better to a calm, respectful, and non-judgmental approach than to being lectured at about their behavior. D is wrong because avoiding sensitive topics entirely leaves the adolescent without needed information and support. Open, private conversation serves the adolescent far better than sidestepping these important health concerns with them altogether. Getting honest health information from a teenager depends on 2 conditions: privacy and the absence of judgment. Both exist for the same reason: to get accurate answers about behaviors that carry real health consequences. Adolescents are forming identity, testing autonomy, and answering to their peer group instead of their family. So the very topics that matter most, like substance use, sex, mood, and safety, are the ones they'll least admit to in front of a parent. Practitioners build this into every visit rather than requesting it as an exception, which would itself look suspicious. They explain confidentiality limits before asking anything, use open-ended questions, and move gradually from less sensitive topics to more sensitive ones. Picture a nurse seeing a 16-year-old for a routine visit. The parent steps out as standard practice. The nurse states what stays private and what must be shared, and only then asks about school, mood, relationships, and substance use, without any visible reaction to the answers. Privacy alone isn't enough. One flash of alarm or a lecture and the adolescent won't disclose again. Confidentiality protects most of what's shared, except when there's risk of serious harm, which is exactly what those stated limits are for. Question 34. A nurse finishes charting at a shared computer station and prepares to step away. Which action best maintains information security? Your options are A. Log off before leaving the workstation. B. Leave the record open for the next nurse. C. Share the password with a co-worker. D. Write the password near the screen. Take a second. Which answer would you pick? The correct answer is A. Log off before leaving the workstation. A is correct because logging off before stepping away keeps unauthorized people from viewing or changing protected records under the nurse's access. This simple habit safeguards client information and the nurse's own credentials. B is wrong because leaving the record open lets anyone who passes by read protected health information. An unattended, logged-in screen exposes client data and violates the facility's information security expectations for staff. C is wrong because sharing a password lets another person act under the nurse's identity, erasing accountability. Credentials are personal and must never be given out, even to a trusted co-worker on the unit. D is wrong because writing the password near the screen makes it visible to anyone nearby and defeats access controls. Passwords must be kept private rather than posted where others can easily find them. Electronic health records changed what it means to leave a chart unattended. An open session at a nursing station is not a small lapse. It is a door left standing open in a busy hallway. A paper chart could only be viewed by one person in one place, and removing it was noticeable. An electronic session has no such limit. It hands full access to anyone who sits down at the screen. Every action in an electronic record, from notes written to orders acknowledged, medications documented, and records viewed, attaches to whoever is logged in. A nurse who leaves a session open owns everything that happens under that name, which is why sharing a password is treated as serious misconduct. Turning a monitor away, minimizing a window, or relying on an automatic timeout leaves the session authenticated and the access live, with the delay built in that is itself the exposure. Logging off is the only action that ends the session and removes the access entirely. Safeguards fall into three categories: administrative policies and training, physical control of spaces and devices, and technical measures like unique identification, automatic log-off, and encryption. Logging off is a technical safeguard, but it only works when a person actually carries it out at the moment of stepping away. Question 35. A nurse is admitting a client who is suspected tuberculosis. Which type of precaution should the nurse implement? Your options are A. Contact precautions. B. Airborne precautions. C. Droplet precautions. D. Standard precautions only. Before I reveal it, which one do you think is right? The correct answer is B. Airborne precautions. B is correct because tuberculosis spreads through tiny airborne particles, so the client requires airborne precautions. This includes a private negative pressure room and a fitted respirator for anyone entering the room. A is wrong because contact precautions guard against spread through touch and contaminated surfaces. Tuberculosis travels through the air rather than by contact, so these precautions would not protect against it. C is wrong because droplet precautions address larger respiratory droplets that fall within a short distance. Tuberculosis particles are smaller and stay airborne, which requires the higher level of airborne precautions. D is wrong because standard precautions alone are not enough for an organism that spreads through the air. The client needs added airborne precautions to prevent transmission to staff and other clients. Airborne precautions protect against organisms that travel in tiny droplet nuclei, small enough to float in air for hours and drift on air currents. Tuberculosis, measles, and varicella are the classic examples. Large respiratory droplets are heavy, travel only a short distance, and settle onto surfaces, so distance and a surgical mask work fine against them. Droplet nuclei are the tiny residue left after those droplets evaporate. They stay suspended, ride air currents, and demand engineering controls, not just barriers. The room is held at negative pressure, so air always flows inward when the door opens, and contaminated air never escapes into the corridor. Air is exchanged rapidly and either exhausted outside or passed through high-efficiency filters. Staff wear a fit-tested N95 respirator or a powered air-purifying respirator, since a surgical mask cannot filter or seal against particles this small. Exam writers love reversing two details. An airborne isolation room uses negative pressure to keep contaminated air in, while a protective environment for immunocompromised clients uses positive pressure to keep contaminated air out. Staff wear the respirator. The client wears a surgical mask during transport, since it contains what they exhale. Droplet precautions cover influenza, pertussis, and meningococcal disease, needing only a private room, surgical mask, and distance. Contact precautions cover organisms spread by touch, like resistant bacteria and C. Difficile, needing gown and gloves. Airborne precautions add the negative pressure room and respirator, identify how the organism travels, and the correct equipment follows. Question 36. A nursing student wants to post about an interesting clinical experience on a social media account. Which guidance should the nurse give? Your options are: A. Posting is fine without using a last name. B. Sharing a room number is acceptable. C. Photos are allowed if the face is hidden. D. Avoid posting any client information or images. What's your answer? Commit to one before I continue. The correct answer is D. Avoid posting any client information or images. D is correct because privacy rules prohibit posting client information or images on social media, even without obvious identifiers. The safest guidance is to share nothing about clients or clinical experiences that could expose them. A is wrong because omitting a last name does not make a post safe, because other details can still identify the client. Privacy protection requires sharing no client information at all on social media. B is wrong because a room number can be linked to a specific client and reveals protected information. Posting it online breaches confidentiality just as a name would, so this advice would be wrong to give. C is wrong because hiding a face does not remove identifying features such as tattoos, settings, or surrounding context. Photographs of clients are prohibited on social media regardless of how the image is edited. There's one rule that governs healthcare students online, and it's absolute: no client information in any form on any personal platform ever. Privacy law was built for a world where sharing meant telling one identifiable person. Social media breaks that model completely, since a post reaches an unbounded audience instantly, gets reshared beyond your control, and persists through screenshots even after deletion. Removing a name does not de-identify a post, an unusual condition the facility your profile already reveals, and the date the post supplies can combine to identify someone, and background photo details like whiteboards, wristbands, and chart screens do the rest. Exam writers test whether you believe certain conditions excuse posting. Client permission doesn't authorize it. Omitting the name doesn't authorize it. A private account doesn't authorize it since sharing escapes control after the first repost. And educational intent doesn't authorize it either. A privacy violation involves client information and carries legal consequences, while posting disparaging comments is a professionalism concern with academic and job consequences. And photos from a facility can trigger both at once. The safest rule: keep your personal account and the clinical setting entirely separate. Question 37. A nurse wants to offer a complementary therapy that does not require special certification. Which therapy can the nurse provide? Your options are A. Acupuncture, B. Chiropractic adjustment, C. Guided imagery, D. Biofeedback therapy. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Guided imagery. C is correct because guided imagery is a complementary therapy a nurse can provide without special certification once the principles are understood. The nurse can use it to help the client relax and manage discomfort. A is wrong because acupuncture requires specialized training and licensing to perform safely. It is not a therapy a nurse can provide without that specialized certification, unlike the guided imagery option here. B is wrong because a chiropractic adjustment is performed by a licensed chiropractor with specialized training. A nurse cannot provide this therapy, so it does not fit what the nurse can offer. D is wrong because biofeedback therapy requires special training and equipment to deliver properly. It is outside what a nurse can provide without certification, making it the wrong choice here. Guided imagery uses spoken description and directed attention to guide a person through a vivid, pleasant mental scene, producing real physical relaxation. Because it relies only on voice and attention, nurses can use it without specialized certification. Focusing on an imagined safe scene shifts the body away from sympathetic stress dominance toward parasympathetic calm. Heart rate slows, muscle tension falls, breathing deepens, and perceived pain and anxiety decrease, because the body reacts to imagined safety just as strongly as it reacts to imagined threat. Delivery depends on preparation, not special skill. The room is quieted. The client is settled with slow breathing, and the nurse describes a scene the client chose, layering in sight, sound, temperature, and smell. The client stays in control throughout, because the scene must feel pleasant to that person, not just sound relaxing on paper. Exam questions test which therapies stay within general nursing scope: guided imagery, deep breathing, progressive muscle relaxation, distraction, music, and repositioning need no extra credential, while acupuncture, chiropractic care, therapeutic massage, hypnotherapy, and biofeedback all require specialized licensure or certification. The organizing rule is simple: techniques built only from voice, attention, and the client's own participation remain within ordinary nursing practice, while anything involving specialized manipulation, instrumentation, or substances does not. Question 38. A nurse assesses an infant who can sit without support and is beginning to use a pincer grasp. These findings suggest the infant is developing in which way? Your options are A, as expected for an older infant, B, ahead of the newborn stage only, C, showing a developmental delay, D, like a toddler in motor skills. Which would you go with? Lock it in before the reveal. The correct answer is A, as expected for an older infant. A is correct because sitting without support and starting a pincer grasp are milestones expected later in the first year. These findings indicate the infant is developing normally for an older infant. B is wrong because describing these skills as only just beyond the newborn stage understates the progress shown. Sitting unsupported and a pincer grasp are well beyond newborn reflexes and abilities. C is wrong because labeling these findings a delay is incorrect, since they match the expected later infant milestones. The infant is progressing on schedule rather than falling behind in development. D is wrong because comparing the infant to a toddler overstates the skill level shown. Toddlers walk and use more refined movements, which this infant has not yet reached. So the comparison is inaccurate. Infant development isn't random. It follows two predictable rules that let us pinpoint an infant's age just from what they can do. Development moves cephalocaudal head to toe, so head control comes before sitting and sitting before walking. It also moves proximo-distal, center to periphery, so trunk and shoulder control precede the arm, and the arm precedes fine finger movements. The sequence never changes, even though the exact timing varies between infants. The mechanism behind every milestone is neurologic maturation, myelination of motor pathways, and the fading of primitive reflexes. A newborn's grasp starts as a reflex, then progresses through whole hand reaching, a raking motion, a crude thumb to palm grasp, and finally the precise pincer grasp, each stage requiring more refined cortical control. Exam questions test whether findings are expected, delayed, or advanced for age, so it helps to hold a few fixed anchors in mind. Head control by 4 months, rolling by 4 to 6, sitting by 6 to 8, crawling by 8 to 10, pulling to stand by 9 to 12, and walking by 12 to 15 months. Don't confuse this with Erickson's trust versus mistrust, which runs alongside but concerns emotional expectations, not physical skill. If a STEM describes what an infant can physically do, it's testing motor development. Question 39. A competent adult client decides to leave the facility against medical advice. Which action should the nurse take? Your options are: A. Physically prevent the client from leaving. B. Notify the provider and explain the risks. C. Tell the client they are not allowed to go. D. Ignore the decision and continue care. Don't overthink it. Which one feels right? The correct answer is B. Notify the provider and explain the risks. B is correct because a competent client has the right to leave. The nurse notifies the provider, explains the risk of leaving early, asks the client to sign the against medical advice form, and documents the event. A is wrong because physically preventing a competent client from leaving is false imprisonment. Clients retain the right to refuse care and depart, so restraining the client here would be unlawful. C is wrong because telling the client they cannot go denies a competent adult's legal right to refuse care. The nurse should inform the client of the risk rather than forbidding the departure outright. D is wrong because ignoring the decision skips the nurse's duty to inform the client and document the situation. Proper steps protect both the client and the nurse, so doing nothing is inappropriate. When a competent client decides to end a hospitalization early, that decision belongs to the client, not the treating team. Autonomy is the ethical principle giving a competent adult the right to control their own body, including the right to make choices clinicians think are unwise. That right to refuse stays intact no matter how strongly the team disagrees. The correct response is a defined process, not an obstruction. The provider is notified. The risks are explained in specific and understandable terms, and the reason behind the decision is explored, since it's often something solvable like pain, cost, fear, or a caregiving gap at home. The boundary that matters is competence. Can the client understand, appreciate consequences, reason through options, and communicate a choice? A confused, intoxicated, or altered client may lack that capacity, but a competent client cannot be physically stopped, and restraining one is false imprisonment or battery. Beneficence feels like the stronger claim when a choice looks dangerous, but for a competent adult, autonomy wins, and beneficence is expressed by informing and arranging, not overriding. Every principle points to the same action, a thorough conversation, followed by respect for whatever the client decides. Question 40. A nurse is planning community health activities. Which activity is an example of primary prevention? Your options are A. Screening adults for high cholesterol. B. Rehabilitation after a stroke. C. Treating a newly found infection. D. Providing an immunization program. Got a guess? Lock it in. The correct answer is D. Providing an immunization program. D is correct because primary prevention protects healthy people before disease occurs. Providing an immunization program shields clients from illness ahead of time, which is the defining purpose of primary prevention. A is wrong because screening adults for high cholesterol is secondary prevention because it detects a problem early. It identifies existing risk rather than preventing the disease before it ever begins. B is wrong because rehabilitation after a stroke is tertiary prevention, which limits the long-term effects of an existing condition. It restores function instead of preventing disease before it starts. C is wrong because treating a newly found infection is secondary prevention aimed at stopping a problem from worsening. It manages illness that already exists rather than preventing it in a healthy person. Public health organizes every intervention into 3 levels, based on one question: where does the person stand in relation to the disease? That single distinction determines whether an activity is primary, secondary, or tertiary prevention. Primary prevention acts before disease begins, strengthening resistance or removing exposure, like immunization and safety measures. Secondary prevention acts during the silent early stage, using screening to catch disease before symptoms appear. Tertiary prevention acts after disease is established, limiting disability and restoring function through rehabilitation and management. This framework exists because illness progresses through stages, from before onset to a silent detectable stage to clinical disease, and finally residual effects. Naming the levels let public health target effort deliberately and made clear the earlier stage offers the greatest return. The same activity considered at different levels. Teaching about diet to a healthy adult is primary prevention, but the same teaching given to someone with diabetes is tertiary because it manages disease already present. A blood pressure check at a screening event is secondary, while monitoring blood pressure in someone already diagnosed with hypertension is tertiary. Whenever a question describes an activity, ask one thing: does this person already have the condition? And is the goal to stop it starting, catch it early, or limit what it has already done? That answer, not the activity itself, tells you the level. Question 41. A nurse enters a room and finds a client reading a religious text who asks to be left alone for a while. Which response is most appropriate? Your options are A. Insist on completing care right away. B. Ask the client detailed religious questions. C. Provide privacy and return later. D. Remove the religious text for safety. Which one is it? Pause the video if you need more time. The correct answer is C. Provide privacy and return later. C is correct because honoring the request for time alone supports the client's spiritual needs. The nurse provides privacy for the religious practice and returns a little later to complete the care. A is wrong because insisting on care right away disregards the client's expressed spiritual need. Unless it is urgent, the nurse can return after allowing the client some private time. B is wrong because asking detailed religious questions intrudes when the client asks to be alone. The respectful response is to provide privacy, not to probe about beliefs at this moment. D is wrong because removing the religious text disrespects the client and serves no real safety purpose. The nurse supports the practice rather than taking the text away from the client. Spiritual care means supporting a client's search for meaning, purpose, and connection when illness has disrupted them. It's not the same as religion, though religion is one common expression of it. Giving a client privacy during a religious practice, then returning later, works because it gives the client something rather than doing something to them. Serious illness raises questions no clinical intervention addresses. Why this happened, what it means, whether suffering has purpose, and whether a life has been worth living. Nursing frameworks recognize that ignoring these questions leaves part of the person outside the scope of care. Spiritual distress measurably correlates with poorer coping, higher anxiety, and reduced treatment adherence. The mechanism of support is about creating conditions, not supplying content. A hospital is built for observation and access. Staff enter without warning. Monitors sound, doors stay open, which is the opposite of what prayer or meditation requires. Closing the door and protecting quiet time is itself the genuine intervention. Exam writers test two nuances. First, respect the client's expressed wish rather than substituting your own idea of engagement. Staying to discuss the reading or offering to pray overrides a request to be alone, however well meant. Second, the nurse's own beliefs stay out of the encounter entirely, because sharing personal faith imposes on a vulnerable, dependent client. Spirituality is the broad search for meaning, present even without religion. Religion is an organized system of beliefs shared by a community. Faith is trust or belief, which may or may not be religious. Assessing what the individual client actually needs, rather than assuming from an affiliation on a form, is what distinguishes competent spiritual care from a checklist. Question 42. A nurse plans activities for a hospitalized school-age child. Which activity best fits this child's developmental stage? Your options are A. A board game with rules. B. Playing alone with a rattle. C. Simple parallel play with blocks. D. Watching a mobile spin. Take a second here. Which answer would you pick? The correct answer is A. A board game with rules. A is correct because school-age children enjoy cooperative play and games with rules. A board game suits their developmental stage and supports the growing sense of competence and social skill they are building. B is wrong because playing alone with a rattle suits an infant, not a school-age child. This activity falls far below the abilities and interests a school-age child has at this stage. C is wrong because parallel play with blocks is typical of toddlers who play side by side. A school-aged child is ready for cooperative games, so this choice is too immature for them. D is wrong because watching a mobile spin is an infant activity meant for early visual stimulation. It offers nothing for a school-aged child who needs more engaging, rule-based play and mental challenge. Play is not just fun and games. It follows a predictable developmental sequence, and knowing which stage a child is in tells you exactly what activity fits. An infant plays alone in solitary play. A toddler sits beside peers in parallel play with little interaction. A preschooler shares and interacts in associative play without organized goals. The school-age child reaches cooperative play built on shared objectives, assigned roles, and rules that apply to everyone. This shift happens because of concrete operational thought paired with the industry stage of psychosocial development. Rules demand understanding that a system applies to everyone, tracking several conditions simultaneously, and accepting outcomes decided by structure rather than by wish. That is why school-age children become so preoccupied with fairness. Matching the activity to the stage matters most in a hospital. A stacking toy suits an infant, push toys suit a toddler, dress-up suits a preschooler, and a board game with clear rules suits the school-age child. Too simple brings boredom, too advanced brings frustration. Play stages, Erikson and Piaget aren't competing frameworks. They describe the same school-age child from three angles: what they do socially, what they're working through psychologically, and how they reason. Question 43. A nurse is pouring a sterile solution into a container on the sterile field. Which action is correct? Your options are A. Lay the cap face down on the table. B. Place the cap face up on the table. C. Touch the bottle to the container. D. Pour quickly so none is wasted. Before I reveal it, which one do you think is right? The correct answer is B. Place the cap face up on the table. B is correct because placing the cap face up keeps the inside of the cap, which contacts the solution, free of contamination. This protects the sterility of the solution the nurse pours onto the field. A is wrong because laying the cap face down sets the inner surface on a non-sterile table. That contaminates the part that touches the solution, so the cap should rest face up instead. C is wrong because touching the bottle to the container lets a non-sterile bottle contact the sterile receptacle. The nurse pours without contact, so the sterile container on the field stays sterile. D is wrong because pouring quickly increases splashing, which can wet the field and cause contamination through wicking. A careful, steady pour protects the sterility of the field during the procedure. Sterile technique isn't a list of arbitrary rules. Every step answers one question. How do you move sterile liquid past a contaminated surface without letting the two touch? Surgical asepsis works in absolutes. A field is contaminated if anything non-sterile touches it, if it gets wet from a non-sterile source, if it drops below waist level or out of sight, or if someone reaches across it. The trickiest rule is the wet field. When solution splashes onto cloth, moisture wicks straight through the fabric, pulling organisms from the non-sterile surface underneath up into the sterile field above, and it looks completely unchanged. That's why the technique looks the way it does. The cap rests inner side up, so its sterile contacting surface stays clean. The label is held against the palm to keep it dry and readable, and the solution is poured from several inches up, close enough to avoid splashing, far enough that the bottle never crosses the field. Remember, surgical asepsis has no partial credit. A field's edges, anything below waist level, and any wet spot are contaminated even though they look identical to the rest. The standard is all or nothing. Question 44. A nurse is responding to a client who is upset. Which statement by the nurse is therapeutic? Your options are: A. There is no reason to be upset. B. You will feel better soon enough. C. Let's talk about something happier. D. You seem upset, tell me more. What's your answer? Commit to one before I continue. The correct answer is D. You seem upset, tell me more. D is correct because naming the feeling and inviting the client to say more acknowledges the emotion and encourages expression. This therapeutic response opens the door for the client to share more. A is wrong because telling the client there is no reason to be upset dismisses a genuine feeling. Minimizing emotions is a communication barrier rather than a therapeutic response to distress. B is wrong because promising the client will feel better soon is false reassurance that glosses over the distress. It avoids acknowledging the feeling instead of exploring it with the client. C is wrong because suggesting a happier topic changes the subject away from the client's distress. Redirecting like this is a barrier rather than a therapeutic way to respond to the client. A therapeutic response to an upset client does two things in one sentence. It names what the nurse observes, and it invites the client to say more. Emotional distress is frequently unnamed. A frightened, angry, or grieving client may not announce it, so the feeling leaks out instead as terse answers, refusal of care, tears, or irritation with staff. Naming the observation aloud gives that client an entry point that did not exist before, and it tests the reading too, since a client who is really just in pain or exhausted will correct it. The mechanism depends on staying open. The observation shows the nurse noticed. The invitation shows the nurse wants to hear more. And silence afterward gives the client room to organize difficult thoughts without the nurse rushing to fill it. Are the piece alone is weaker than the pair? Exam writers test this against responses that feel supportive but shut the client down. Telling someone not to worry dismisses the feeling. Promising everything will be fine offers what no one can guarantee. Changing the subject removes the topic entirely, and asking why demands justification instead of description. Observation, broad openings, reflecting, silence, and general leads are all forms of staying with the client. What unites them is that the client keeps control of the content while the nurse supplies attention and structure. Question 45. A nurse caring for a client with a nasogastric tube notices dark coffee ground drainage. Which action should the nurse take? Your options are A. Flush the tube with extra air. B. Continue care without concern. C. Report the finding to the provider. D. Remove the tube right away. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Report the finding to the provider. C is correct because dark coffee ground drainage can indicate bleeding in the stomach. The nurse reports this finding to the provider promptly so the cause can be investigated and treated for the client without delay. A is wrong because flushing the tube with air does not address possible bleeding and could worsen the situation. The nurse reports the coffee ground drainage rather than flushing the tube with air. B is wrong because continuing care without concern overlooks a sign of possible gastric bleeding. Coffee ground drainage needs to be reported, not ignored, so the underlying cause can be found and treated. D is wrong because removing the tube right away is outside the nurse's independent action and may not be needed. The nurse first reports the finding to the provider rather than pulling the tube. Coffee ground drainage from a nasogastric tube is dark brown or black granular material that forms when blood is exposed to gastric acid. Hemoglobin reacts with hydrochloric acid and converts to acid hematin, which is dark and particulate. This appearance signals blood that has been sitting in the stomach, not blood pouring in actively, and it means the provider must be notified. Normal gastric drainage is clear to pale yellow or greenish, sometimes with mucus. Any shift toward red, brown, or black means blood is present. Bright red drainage means active bleeding with no time for acid contact, while coffee ground material means bleeding that occurred over time and may be slowing, stopped, or continuing at a lower rate. This dark granular look comes from a specific chemical reaction. Hemoglobin combines with hydrochloric acid in the stomach and is converted into acid hematin, a dark particulate compound. That transformation is exactly why the drainage looks like coffee grounds rather than fresh red blood. The tested distinction is the correct action. Report, don't intervene independently. Removing the tube eliminates decompression and monitoring access, and irrigating disturbs any clot without diagnostic benefit. Monitoring or documenting alone delays care, so the nurse must assess and notify the provider promptly. Identify the color, the location, and how long blood has contacted acid and every related finding, from melena to hematemesis to bile, sorts into place. When it's new coffee ground drainage, the nurse's job is accurate assessment and prompt communication. Question 46. A nurse is preparing to count a client's respirations. Which action helps ensure an accurate measurement? Your options are A. Count without telling the client. B. Ask the client to breathe deeply. C. Tell the client to hold still and count. D. Have the client count their own breaths. Which would you go with? Lock it in before the reveal. The correct answer is A. Count without telling the client. A is correct because clients who know their breathing is being counted often change their pattern. The nurse counts respirations without announcing it, so the client breathes naturally and the rate stays accurate. B is wrong because asking the client to breathe deeply changes the natural pattern the nurse is trying to measure. Respirations are counted while the client breathes normally, not on the nurse's command. C is wrong because telling the client to hold still and count alerts them that breathing is being watched. Awareness alters the pattern, so the nurse measures respirations discreetly instead of announcing it. D is wrong because having the client count their own breaths makes them conscious of the pattern and changes it. An accurate count requires the client to be unaware that respirations are being measured. Respiration is the one vital sign that changes the moment a client notices it's being measured. That's because breathing, unlike temperature or blood pressure, is under both automatic and voluntary control. The medulla and pons run breathing automatically based on carbon dioxide levels, but the cortex can override that rhythm at will, which is exactly what lets a person hold their breath, talk, or breathe deeply on purpose. The workaround is simple. The nurse keeps fingers on the wrist right after counting the pulse, appearing to still count it, while actually watching or feeling the chest rise and fall. Resting the client's arm across the chest makes each breath easier to feel. One respiration means a full cycle of breathing in and out together, not each phase counted separately. Regular adult breathing can be counted for 30 seconds and doubled, but irregular patterns, infants, or clients in respiratory distress require a full 60 seconds for accuracy. Depth, rhythm, effort, and accessory muscle use all matter too, since the rate alone only tells part of the story. Any answer choice that tells the client to breathe normally or count along defeats the entire purpose, because awareness itself changes the breath. An accurate rate always depends on timing, technique, and the client's condition in that moment. Question 47. A nurse is explaining hospice care to a client's family. Which statement about hospice care is accurate? Your options are: A. It focuses only on curing the client's illness. B. It focuses on comfort and quality of life. C. It is only provided in hospitals. D. It requires stopping all symptom care. Don't overthink it. Which one feels right? The correct answer is B. It focuses on comfort and quality of life. B is correct because hospice care focuses on comfort, dignity, and quality of life when a cure is no longer the goal. It supports the client and family through the end of life. A is wrong because hospice care does not aim to cure the illness anymore. Curative treatment is stopped, and the focus shifts to comfort, dignity, and the client's quality of life. C is wrong because hospice care is provided in various settings, including the home, not only hospitals. Saying it is only in hospitals misrepresents where hospice care can be provided. D is wrong because hospice does not stop symptom care. It emphasizes managing symptoms for comfort. Saying that all symptom care stops misstates the purpose of hospice care entirely and completely. Hospice shifts the goal of care from curing disease to maximizing comfort and quality of life for people whose prognosis is measured in months, not years. As 20th century medicine expanded, death moved into hospitals, prolonged by interventions that extended dying without easing it, while families stood on the sidelines. Cicely Saunders founded the modern hospice movement in 1960s London, arguing that dying people need their own model of care and that suffering itself deserves treatment. Hospice reorganizes what care aims at. Aggressive symptom management becomes the primary clinical work, treating pain, nausea, and anxiety without the usual dosing ceilings. An interdisciplinary team of nursing, medicine, social work, chaplaincy, and volunteers supports both patient and family around the clock. The key exam distinction: hospice is not withdrawal of care but redirection of it. Treatment often intensifies, and it does not hasten death. Enrollment is reversible, and hospice is a specific, time-limited form of palliative care, which itself can accompany curative treatment at any stage of illness. When a family asks what hospice means, the answer is comfort, a responsive team, support for them too, and a choice that can always be reversed. Question 48. A nurse is preparing to perform several tasks. Which task requires the nurse to use surgical aseptic technique? Your options are A. Giving an oral medication, B. Providing routine perineal care, C. Measuring a client's temperature, D. Inserting a urinary catheter. Got a guess? Lock it in. The correct answer is D. Inserting a urinary catheter. D is correct because surgical asepsis or sterile technique eliminates all microorganisms and is required for invasive procedures. Inserting a urinary catheter enters a normally sterile area, so it demands sterile technique rather than clean technique. A is wrong because giving an oral medication is a clean task that calls for medical asepsis. Because nothing enters a sterile body area, sterile technique is unnecessary for this routine oral administration. B is wrong because routine perineal care reduces the spread of microorganisms but does not require a sterile field. Clean technique is sufficient since the task does not enter a sterile body cavity. C is wrong because measuring a temperature is a clean procedure performed with medical asepsis. The thermometer does not enter a sterile site, so the high level of sterile technique is not needed here. One question decides whether a procedure needs sterile technique or clean technique. Will it enter a normally sterile body area, or does it stay on a route that's already colonized with bacteria? Skin, the mouth, and the colon carry dense populations of organisms that cause no harm where they naturally live. But the bladder, the vascular system, the peritoneal cavity, and the joints are normally sterile, so any organism introduced there meets far weaker defenses. Urinary catheterization shows the mechanism clearly. The urethra opens onto colonized skin, while the bladder above it is sterile. The catheter creates a direct, ongoing pathway between the two, which is why catheter-associated infections are so common and why insertion demands sterile gloves, drapes, and antiseptic prep. Nasogastric tube insertion is a classic trap. The nose and stomach are both colonized, so clean technique applies. A rectal suppository is similarly clean, not sterile, while catheter insertion remains the true sterile case because it targets a sterile cavity. The real question is never how invasive a task feels, but whether its destination is normally sterile. And that single distinction, separate from standard and transmission-based precautions, is what the exam is testing. Question 49. A nurse is teaching a client with a respiratory infection about cough etiquette. Which instruction should the nurse include? Your options are A. Cough openly to clear the lungs. B. Reuse the same tissue throughout the day. C. Cover the mouth and nose when coughing. D. Skip hand hygiene after coughing. Which one is it? Pause the video if you need more time. The correct answer is C. Cover the mouth and nose when coughing. C is correct because covering the mouth and nose when coughing keeps respiratory droplets from spreading to others. Combined with prompt hand hygiene, this is the heart of respiratory hygiene and cough etiquette. A is wrong because coughing openly releases droplets into the air around other people. Cough etiquette exists to contain those droplets, so this instruction would spread the infection rather than limit it. B is wrong because reusing the same tissue keeps moist secretions and organisms in hand and spreads them to surfaces. Tissues are used once and discarded promptly to control the spread of droplets. D is wrong because skipping hand hygiene after coughing leaves organisms on the hands to transfer to objects. Cleaning the hands after contact with secretions is an essential part of cough etiquette. Cough etiquette is a set of respiratory hygiene practices that stop germs at the source before they ever spread to another person. A single cough launches thousands of droplets at high velocity, a sneeze even more. Larger droplets land on surfaces where germs survive for hours, while smaller ones float in the air which is exactly why respiratory hygiene became its own standard precaution. The technique matters, coughing into a tissue that's discarded immediately, or the inner elbow when no tissue is near, blocks droplets without contaminating a surface. Coughing into bare hands is the harmful habit, since hands next touch doorknobs, keyboards, and other people, turning a respiratory exposure into a contact one. Students often mix up two categories of measures. Source control, like cough etiquette, masking the symptomatic person, and staying home, keeps organisms in. Recipient protection, like a respirator on staff, a negative pressure room, or vaccination, keeps organisms out. Hand hygiene works both ways. Whenever a STEM describes a control measure, ask whether it's keeping organisms in at the source or keeping them out at the recipient. That single question reveals its purpose and where it belongs. Question 50. A nurse is identifying clients at increased risk for a body image disturbance. Which client is at greatest risk? Your options are A client with new one-sided paralysis, B, a client recovering from a minor cold, C, a client after a routine eye exam, D, a client with a small cut on the finger. Take a second. Which answer would you pick? The correct answer is A, a client with new one-sided paralysis. A is correct because a stroke that causes paralysis on one side changes body function and appearance, raising the risk for a body image disturbance. This client faces the greatest adjustment among those listed. B is wrong because recovering from a minor cold involves a brief, temporary illness with no lasting change. It does not threaten body image the way a major change in function does. C is wrong because a routine eye exam is a simple check with no effect on body structure or function. It poses essentially no risk for a body image disturbance in the client. D is wrong because a small cut on the finger is a minor injury that heals quickly. It does not produce the lasting change in function or appearance that threatens body image. Body image is the mental picture we hold of how our body looks, moves, and is perceived by others. It forms slowly over a lifetime, so it cannot be revised on the timeline of a sudden illness or injury. Risk depends on how sudden, visible, permanent, and functionally damaging the change is. Functional loss matters most, because losing the ability to walk, speak, or control elimination changes what a person can do, not just how they look. Meaning is also personal, so the same injury affects different people differently. When illness or injury changes the body abruptly, the internal picture and the new physical reality separate. That gap produces genuine grief, moving through shock, denial, anger, and eventual reorganization, not something resolved by simple reassurance. Students often blur body image with self-esteem and role performance. Body image is the physical picture. Self-esteem is the evaluation of personal worth. And role performance is fulfilling expected roles as parent, worker, or partner. New paralysis frequently disrupts all three at once. When a question compares several clients, it is asking which one faces the greatest risk across these variables together, not for a single definition. And that wraps up our full practice review of the ATI Fundamentals exam. Want more practice? Our website is just a click away, right there in the description below. You'll find hundreds of free practice questions plus complete study guides to help you learn every step of the way. Whenever you're ready to keep building your skills, head on over and dive right in. Subscribe to keep going with us, and good luck on your ATI Fundamentals exam.